This podcast is for educational purposes only. Please consult your doctor before changing any medical care. This information, products, or comments contained within this podcast is not approved by the FDA for the treatment or diagnosis of any disease. Although we attempt to keep the information up to date and current, we cannot guarantee the information is up to date at the time of this recording. Individual results will vary. No one should expect the outcomes or results mentioned or described in this podcast. Health shares do not constitute health insurance and do not provide a guarantee to pay for your medical bills. Please consult your broker, general counsel, and/or doctor before changing your healthcare plan. Envita and Envita Health makes no guarantees for outcomes and results. Thank you for joining us. I'm Dr. Dino Prato, founder and CEO of Envita Medical Centers, here with Dr. John Oertle, who is one of the medical directors and helps with research and development at Envita. So we have a case of a head and neck cancer today, and I think this is a good one. You know, we're always encouraged to share cases with people and help, everybody understand more about what we do here at Envita. So Dr. Oertle, or John, let's go ahead and get started. So this is a 50-year-old male, and I'll let you, as you know, you lead our presentations at the Molecular Tumor Board. So go ahead and jump.
Yeah, this is a 50-year-old male, and he was diagnosed with head and neck squamous cell carcinoma. And so squamous cell, you have squamous cell in your skin, but he had specifically a lesion in his neck, and he came on in. He hadn't had any treatment yet, because this gentleman, I have to say this gentleman knew about Envita before. So he'd heard about Envita. He had friends that had come to Envita and had done incredibly well. He had known about us. And once he got the diagnosis that he had head and neck cancer, with that biopsy, his first stop was he literally drove on out and showed up at our door. Now, again, I don't recommend this, because usually, again, talk to call Envita. We have PCCs that's going to be able to look and make sure collect records and make sure that you're discussing it with the doctor team to be able to make sure you're a good candidate before traveling out here. But he wasn't. It was just, I know where I'm going. I'm going to go to the best. And he comes on out here into our waiting room. And we said, okay, let's get your records. Let's get everything going and moving. But this is the gentleman who came on out. What we actually saw is that we ran a PET scan. We made sure that there was no other disease anywhere else in the body. And we didn't see anything else. But besides that tumor, that really large tumor that was in that the neck region, we did see that he had a history of candidiasis, which is a fungal infection that he has that can be inflammatory.
Let me jump in here, because I want to add to this. Oftentimes, patients who have chronic sinus infections, they're not always bacterial. They're oftentimes fungal. In fact, there was a study years back. And so these are sometimes resistant, and people can have ongoing Maricon, other types of these nasal infections that are resistant to treatment. And infections can be predispositions to cancer. Okay,
that's exactly. And Dino and Dr. Prato, that fungal infections, the toxins that they produce are called mycotoxins. And it's not all fungal infections that create carcinogens, but there's a good handful of fungal infections that create the toxins that are carcinogenic, meaning that they lead to cancer development. And they push biomarkers that lead to cancer development in the body.
Let's move on, because we could spend a lot of time just talking about infections.
So when you came on in, what we see is that we run a cancer cell-free DNA. Looking at this is a blood test where we're able to see the actual cancer cell DNA floating around in the bloodstream. And this is where this is not healthy cancer cells, the DNA, or this is not healthy DNA of the body. This is mutations of that cancer that's now floating around in the bloodstream. This is one of the liquid biopsy diagnostics that we see. And it was, he had it. This is not normal. Even it's in low quantities, because it's only localized here to the actual, the neck. It isn't in very high quantities, which does mean that he has a good prognosis that we're able to treat, that he's going to respond well to treatment. But what you see is that that's not normal, and that should not be in the bloodstream.
And let me add that we run lots of tests and we have lots of pipelines of bioinformatics that we run through to select care. But we're pointing out, it's just hard on these slides to go through a laundry list of genetics. We're pointing out what we think were some of the more important markers for the presentation, and really understand that these genomic markers, play a role in understanding it's part of a prognostic marker too when you're looking at these mutational rates, right? These alleles and so forth. So let me move on here. And so let's take a look here. You've got the image. I'll let you.
All right. So this was the first PET scan that we ran, and when you run a PET scan, it's essentially you inject some dye, and it goes to where the cancer is at, and it lights it on up like a Christmas tree. So what you see is where that arrow is, that yellow orange arrow is pointing to is the tumor in the neck. And that's lit up, as you can see, very, very bright on the actual image. The other stuff that's looking is just normal. That's normal for a human body to be able to see that. But that arrow where it's pointing to that little sphere is not normal and should not be there. And there you see a lateral view of the same man, the same tumor. You can see it's actually a little bit more wide than it is tall as far as that goes. But that's right there in the neck.
Yeah, and these cancers are can become really difficult if not treated correctly early. They can start to get pretty complex. So let's move on.
So the concerns there that can go on is that you have a lot of sensitive tissue in those areas. There's obviously the tongue, the larynx, the vocal cords, how you swallow. And so oftentimes when you actually see this, you have to be precise with your head and neck cancers, because if you're not, then it can cause a lot of collateral damage around those tumors. It can start to invade into the actual, the stop breathing, stop the ability to be able to swallow, stop the ability to be able to speak. And so when you see these, it's really a critical thing to be able to be precise with these cancers because of the very location. Okay, so this is just the impression as you're seeing where the actual lesions are at of the actual PET scan. We can certainly move on from there as well. Okay, so we recommended a 12-week treatment, and we provided GTF chemotherapy. What this is genetically targeted fractionated chemotherapy. So this is chemotherapy that is designed around the patient's biomarkers and the actual genetic precision targets, and it's in a low fractionated dose. We call it metronomic dosing of chemotherapy.
So,
we use biological modifiers to be able to help attract the chemotherapy directly to the tumor.
John, I'm going to pause here because as we go through these, just from years of experience, the genetically targeted fractionated chemotherapy, along the way where we say Envita has a proprietary treatment, it's been developed over 2 decades. A conventional oncologist will look at this and either say one of two things. This patient, as you know, will get well, and they'll say it's a spontaneous remission, or we have a lot of those, praise God, right? We get a lot of those. Or what we're doing really isn't proprietary because they're not into molecular targeting. They don't really understand the depths of bioinformatic pipelines. They don't work in that type of detail. But genetically targeted fractionated chemotherapy, which we've been doing for quite some time now, involves a multi-step process that begins with a series of pretty advanced genetic tests. And then those tests help us to isolate the better target. Where in the conventional model, this is the difference, it's a big difference. They will typically use the National Comprehensive Cancer Network, a cookbook of oncology, for whatever it is. If it doesn't work, they move to line 2, and then they might run what we would consider is a watered down version of genetic testing, because Envita goes into very deep testing. And then if they don't have an actionable target, which is FDA approved for that particular cancer type, you're done. So that's why oftentimes they don't bother, because even if they do run it, they're not going to get maybe good actionable targets. Where Envita then goes and builds on and off-label drugs to hit those actionable targets. This is just the GTF. Then when the GTF is delivered, we use metabolic tools to access it to the tumor. So cancers can, when you look at metabolic factors, inflammation, insulin, anaerobic versus aerobic, these different parts of metabolic activity, which play part of the metabolome and proteomics inside of cancer, we use those to find the best moments within the treatment to deliver and take advantage of the treatment plan in this micro dose. So the difference is for the average person to understand is when we have the right targets, we don't guess. And so we don't need 100%. We can do 20, 15, 10% of the drug, which reduces a side effect significantly and starts to actually get targeting. Then we also use, along with this, nanotechnology. Yes, it's available. We're using it to deliver the medication. So when you understand this type of difference, and just because I'm going to keep doing this because it's unfortunate that you have the presumption of standard oncology that they presume that it's really not any different, or it's significantly different, to the point where the majority of patients that we see fail care. They're in round 2 or 3 of care, and then they begin to have response, a measurable response within Envita care that helps them to either lengthen their life or respond to treatment. But again, that is a significant difference. It's just targeting, and precision oncology will be the standard, and it's just not there yet. So I just want to talk about GTF a little bit because you keep hearing over and over, well, it's all the same. It's not. And alternative medical doctors don't do this. This is precision. Conventional doctors don't do this. This is precision. It's unique to Envita's development of care. And I'm happy to tour any one of those doctors. I invite them to come and understand the difference that precision can make in care. So I'll let you continue. I want to explain this because patients often don't know. And what they don't know can lead them to the wrong direction. So by having knowledge, they can make better decisions. So go ahead. And then the next one.
You're talking about a single, this is, this is precision chemotherapy targeting with our GTF. Okay. We then did precision immunotherapy targeting. What you're seeing here, the immunotherapy with a PD-1 inhibitor. Again, that's just a baseline. This is your Keytruda, Opdivo, but this is one of these that actually has a very good target for this specific cancer. We knew that this was going to be effective for this gentleman. And this is where that's just the tip of the iceberg. What you see here too, down at the bottom, AAIT immunotherapy. This is an immunotherapy that was developed around the patient's own immune system, where it's developed in a biological laboratory to be able to increase his own cells, the dendritic cells and the natural killer cells. And then we hone the ability of the actual cancer cell to that. We teach the immune system how to target it in a laboratory, and then we redeploy it back into the body. It's called adaptive autologous, meaning your own cells, immunotherapy. This is one of the most powerful and precision treatments because it's based upon your own body's immune system that actually targets the cancer. This was a great thing that actually elevated this cancer patient's remission and complete response. Okay. We then also did precision radiation therapy. Okay. You don't just do radiation therapy that's an external beam because it creates a lot of again, those tissues that are around the area, okay? When we use radiation in a very sophisticated way to be able to make it sure that it's precision, directly targeted to the area, radiation can also be very immune supportive as well. Just like chemotherapy, when it's used in the right dose and the right type, it's immunosupportive. So it doesn't kill the body, it protects the body, but helps to be able to kill the cancer effectively, okay? We also used precision adjuvant phytotherapeutics. These are natural medications that are supports that make the therapies more effective. They're actually supportive to the body's immune system. They're supportive to the body's tissue. They help to protect the actual tissue and advance the ability of the chemotherapies and the radiation to be able to become more effective.
Before we go further, I want to take a few minutes on this. And also I want to bring up an image maybe that can help people see things better. The phytotherapeutics are also typed through genomics. They're also typed through miRNA and through messaging. And what you'll see is oftentimes, and I won't go into, but you'll learn about the SOT type therapies that are discussed in integrative medicine. And their job is to try to silence miRNA. But the problem is what we saw at least 7 years ago in work was it just wasn't as effective, anywhere near as effective as what we're seeing clinically, because the best way is to work in concert with the genetic therapies, immunotherapy and chemotherapy targets. When everything's working in concert with each other, the effects are far better. Let me share something here just for a second. I'm going to pull up an image that might help us kind of get a better picture of what we're doing here. So it's really hard to see all this technology, John, because we're talking about it because we've been doing it for all these years. Can you see that image there, John? Is that visible?
Yes. Yep, I can now.
So this is what we're talking about when we talked about the AIT. So down on the left-hand corner, you'll see that in this particular image, the immunotherapy that's used as an oncolytic viral therapy, which goes in and it only kills the cancer cell. It doesn't affect the healthy cells, and it starts to actually destroy it. But then, as you see these little green that look like gems, these are antigens. So the cancer starts to squeeze like an orange the information so that it spreads to the immune system, and then the dendritic cells to the natural killer cells, and then they go out and seek and kill the cancers. And then you can use PD-1 inhibitors, checkpoint inhibitors, others that help them to hit their target. But what's unique about what Envita does is not only do we can utilize these and other immunotherapies, but we can expand the dendritic cells, make them peptide specific. We can expand the natural killer cells so that we know that they already have high cytotoxic activity. And we do that in our international facility to allow for advanced immunotherapy. So the reason I wanted to share that and kind of, discuss that briefly was because my goal here was to give a visual to this advanced immunotherapy. This is not being done in standard oncology. And these are autologous. They're from your own body, taught to attack your tumor. It's been a process we've developed over 15, 16 years from our early days. And even from the early 2000s, we started building taking the cancer cells or taking the immune system to identify cancer cells and fight it at a very advanced level. And, that's innovation. So when we talk about Envita having proprietary treatment, we just want to make that clear because, it's interesting how, and I say this with great respect, the rank and file oncologists, 25, 30 patients a day at all the standard cancer centers, hospitals, are doing standard care. This is not standard care. Yeah. That doesn't mean standard care isn't good. It just means that the patients we're seeing prefer precision, and or most of them have failed standard of care and need precision. And our opinion is the sooner you deploy precision, the better it is. And so as we continue here, I'm going to, bring us back into our slide deck, to the next slide deck here. So here we have, if you can see that, can you see it well there?
So I'm going to go back to what I was saying earlier, that this is the DNA in the bloodstream of the cancer that shouldn't be there. And what you see is that immediately after 1 month, it's no longer detected.
That's right.
And then it's no longer detected after 2 months after deploying the actual precision therapies that we were deploying. So what you're seeing right now is that this is a leading indicator. Okay. There's many different biomarkers that we run, that many of the biomarkers that are actually done in standard oncology as well are lagging indicators. Imaging is a lagging indicator. It doesn't give you immediate information as far as what's happening right now. The cell-free DNA is actually a leading indicator.
That's right.
One of the leading indicators. And when you start to be able to see that this is, even after a month of deploying the treatment, you're seeing that it's removed and the patient is responding according to how we want him to respond. And so when this happens, we say, we're doing a good job. We keep doing it.
That's right. And let me just say, after, in our field, when you just to understand the difference, you don't see this with vitamin C therapy alone, right? You don't see that. So people have to understand when you're talking about, alternative medicine, and it has its place of supporting people after chemo, it's supportive. It's there to support the patient. When you're talking about conventional care, it does none of this work. But when you get into precision and the different processes we've developed over the years to target it, you start to see that these leading indicators, CT, circulating tumor cells, CT-free DNA, and others, metabolic, metabolomes, and so forth, this data, it starts to become very clear that the patient's responding to care and that we're on the right track and we want to continue care. And so here, I'll let you continue. You can see the graph of these markers dropping.
This is just a graph. It's just showing that, again, it was elevated and then it literally within 1 month, it is gone.
These
Absolutely gone.
these confirmatory signs are a very important role that we use as early indicators, because oftentimes in cancer, the problem is the doctor doesn't know how the patient's responding. They might look at a tumor marker that might be going up and down and then wait for imaging 3 months later. But we can tell immediately with a number of markers that give us short-term response data, then to go towards long-term response data, which the goal is to go into remission. That's how you get there. It's these, right. It's the details of these steps that get you there. So let's go here. Now we've got the imaging.
All right. So I always like to say the proof is in the results. And so this is where, when you start to see it, this was, again, over a couple of months. And as you can see, this is the same person. And you see where that arrow is pointing. That's the old PET scan that we just talked about, where that lesion was in that sphere. You don't see it in the second one. It is completely gone.
And
it
here
has
we'll
been,
go to the side image.
And then you see the side. There's that tumor. It's lighting up. And then you see it's absolutely gone in that November scan. And so you're seeing that patient is a complete response. And it's not just the image in the lesion in the neck, but it's also in the blood. The blood. You're seeing it completely gone.
So how can we be most certain, with the best tools we have, that this disease won't return and that the disease is going to stay in remission? This is an important question, because in most oncology, the answer is, well, there's no way to know. We'll watch and wait, we hope. But how can we increase that certainty? I mean, we can never be 100% certain, but how can we take technology to move us into a higher degree of accuracy so that we can hold the remission so the person can live longer with even greater quality of life?
Yeah, so we have a couple of ways. One, we continue to run those biometric markers to be able to make sure that the body is actually, that the markers are signaling health, not disease. Okay.
That's right.
And we run those continually, and we want to make sure that the body is continually signaling health. The other thing is that long-term remission is available because of immune system health. The body's immune system is a critical thing that ensures that the patient is going to have a higher likelihood of long-term remission and never seeing that cancer return again. Because when the immune system gets it, this is why it's so important that everything we do, even the precision chemotherapy, is immunosupportive. The precision radiation therapy is immunosupportive. The precision immunotherapy is immunosupportive in a very advanced degree. But everything, I always say that, again, that long-term remissions for most cancer patients is because the immune system finally recognizes and the body becomes healthy and is able to have a healthy metabolome and is able to help support that immune system to be able to function to recognize the cancer. And so, and what's happened? We've continued to run that, and that gentleman has continued to be able to receive, again, favorable biomarkers, favorable health. And that gentleman, I can safely say, is healthier today than he ever was, even going through cancer therapy.
So the key here I want to put into also perspective is, you saw that there was an infection, right? So
that's correct.
When you're talking about immunity and helping somebody, this is where we go to the cause. This is why, when people ask, one of the advantages we have in our training is that we look at the causes and not just the symptoms of disease, right? Where an oncologist likely would not put that together or be interested in that. I can pretty darn sure from the many that I know and have spoken with that wouldn't be something they would be addressing. They would just say, well, if something happens, go see your primary care. But this person has a chronic fungal infection, mycotoxins that can be carcinogenic. And so as part of ongoing care and home care, we're doing very simple things to help eliminate that fungal infection, reestablish the immune system in that area with the goal of maintaining, and the patient's been doing very well. So
I'll give you this example. It's not just carcinogenic, but those mycotoxins are immunosuppressive. There's currently big pharmaceutical companies that are creating drug trials right now, based upon mycotoxins that come from mold, to be approved for transplant victims who need an immune suppression drug so that their body doesn't reject the transplant. And this is coming from mycotoxins, from those fungal infections. And so this is where it suppresses immunity and it causes cellular changes within the actual DNA of the cell to be able to push those mutations, causing them to either not die off, called apoptosis, or advance the actual progression of the disease so that it's too rapidly growing.
So I'm so glad you brought that up, because with what some of the work we do here at Envita, we work with infectious disease and a lot of tick-borne illness. And a lot of these patients have MARCoNS. They have fungal infections, sinus, upper respiratory type infections that need to be treated. So we have a lot of experience. There's a correlation between infection and cancer.
Yes.
And oftentimes it's ignored. Everybody thinks all head and neck or lung is smoking. It's not. I mean, there's a lot of carcinogens in today's environment, and it becomes important that we treat the cause and not just the symptoms. Anyways, not to make our video super long, because we can go on about this stuff for a long time. We love the work that we do. But John, thanks for joining me. And I also want to say to all of you, thanks for joining us. May the Lord bless you on your journey to healing. Hopefully this was helpful and gave you another insight of how we approach cancer. And if you have any questions, feel free to reach out. We're here to help you in any way that we can. So God bless you, and we wish you the best on your journey to healing.